Hello, everyone. I will just try to get my slides on. Can everyone hear me well? Okay. All right. So I will start today by just introducing the topic, which is basically an educational overview of what we as pediatric hematologists, oncologists see as treatment failures in our daily grind, and where CAR-T is potentially a beacon of hope for many of our children who are battling difficult cancers. So I picked the word opportunity because this word kind of jumped out at me. So most of our colleagues in pediatric hematology oncology are optimists. So the pessimist sees difficulty in every opportunity, but we see the opportunity in every difficulty. So I hope this talk is going to be more inspiring than deflating. So a brief overview of what I'll try to cover as time permits. I'll just talk about the spectrum of childhood cancers, focusing particularly in where the unmet needs are. I will, because we've got quite a mixed audience here, I will just have a very quick few slides on CAR-T and what it is. I will then talk about the blood cancers, the solid tumors, and talk about some of the difficulties faced in the translation of CAR-T in these therapies. And then we will talk about some of the CAR-T designs and some of the hacking that's been going on to try to make CAR-Ts work better for all of us. So first we start with the spectrum of childhood cancers and where our unmet needs may be. So if you look at this diagram here, childhood cancers affect every decade up to age of 20. And in the first decade, you see that this is predominantly blood cancers, leukemias, and lymphomas. Across decades, you'll see a bigger proportion of leukemias in a younger age group, and this is overtaken by lymphomas in those over 10. The second commonest cancers that we see are the brain tumors, and brain tumors make up the second largest group of cancers and the largest group of solid tumors collectively. You also see a group of neuroblastomas in the younger children, and in older children we have the sarcomas, as well as the bone tumors constituting the third largest group of solid tumors. So I'd like to bring your attention to the two groups two baskets of diseases or difficult to treat diseases that I feel needs the most help translationally, and hopefully immunotherapy is one way which we can approach these cures. So the first group are the childhood cancers that we can cure, but we cure at a very high cost. And by this, I mean the cost, the late effects of transplantation, of irradiation, of intensive chemotherapy, of mutilating surgeries, and of course the financial toxicities of many of the better treatments that we have nowadays, such as anti-GD2 antibodies. Of this group, the largest group of children are those that have relapsed refractory leukemias. And there are some that are truly difficult, like the infant leukemias that are MLL rearranged, GMML, FLT3 AMLs. And we also have the high-risk neuroblastomas, the medulloblastomas, and the high-risk sarcomas in this group. You can see that irradiation really increases the risk of second neoplasms as well as any adverse events 20 years from the end of treatment. And this is something that we owe it to our children to try to improve. Just as an example, advanced stage endemic positive neuroblastomas, this is the typical regimen that a preschooler with neuroblastoma would have to undergo in order to achieve a 50% cure rate. Chemotherapy, surgery, nuclear medicine, autologous transplant, which is really just halfway through and not the end of their treatment, followed by radiotherapy, GD2 antibodies, and then some maturation therapy. And this, of course, leaves profound late effects in all of these survivors. And so we like to think about whether we can do the same for them with more tolerable treatments. In KK, our neuroblastoma survival is about 50% in the contemporary cohort. But as you can see, because of the unaffordability of anti-GD2 antibodies, our high-risk group still hovers at around 20%. The next group of childhood cancers that breaks our heart are the incurable childhood cancers. And these are predominantly neuro-oncology diseases. And that's why I really respect my neuro-oncology colleagues. So the incurable cancers that we have are diffuse intrinsic pontine gliomas. And in that basket as well, all the high-grade gliomas, most of the ATRTs below 3 years of age, and most of the multiply relapsed solid tumors and leukemias. Go on to CAR T cell therapies and just introduce this as a biological concept to those not familiar with it. And just remember that this is actually just one tool in the shed of many, many other immunotherapies that we can give, and many, many immune effector cell therapies there are. So CAR T is really very clever engineering of a T cell by which antibody, the antigen recognition site of the antibody, which we call the short chain variable fragment up here, is genetically engineered such that it attaches to a co-stimulatory domain, which sends a signal to, and then a CD3 signaling domain for the T cell to be activated. And with this 3 signals, the T cell is activated and specifically targets the cancer to which it is activating against and kills it by releasing cytotoxic granules. There are many generations of CAR T. The first CAR T was not very effective, being just the scFv fragment, a hinge, and then just the signaling domain. Probably the inflection point came about when the co-stimulatory domain was introduced, and this resulted in a very effective CAR T model, which has continues today. And there was some investigation into adding 2 co-stimulatory domains to the model, but this has not proven to be better than the 2nd generation CAR. So CAR T is not something that's come about in the not even in the last decade. It's actually been in the making for about 30 years now. So this started with the first generation of CAR T cells in the early 1990s, but this did not produce very much clinically astounding results. And then I think that the next light bulb moment came with the co-patenting of the 2nd generation CARs based on the work of Dr. Dario Campana, who's in NUH, as well as Carl June, where the 2nd generation CARs with the 4-1BB domain was proven to be very effective against CD19 B-cell lineage diseases. And this went on to then rapidly be translated, and eventually a breakthrough therapy just based on a pivotal 2B trial was launched in 2017. And this has really changed the landscape of our relapsed refractory BLL treatments. The other significant milestone is also the use of CRISPR-Cas9 genome editing in CAR T cells since 2017. And this has also been quite a useful tool in overcoming many of the challenges, which I will present in a while. So I probably can skip this slide. This is really CAR T therapy where cells are taken from the patient in an autologous setting. It's brought into the lab or the manufacturing facility, and it's transduced to the virus to make the receptors and to make these special CAR T cells, which are then sent back to the patient and infused. Prior to infusion, the patients go through some chemotherapy, and this is quite important. This is actually very important because this actually creates a space, an immunological space for the CAR T cells to expand and become effective and persist in the body. So we'll talk about some of the hematological malignancies. What are the successes and the limitations of the current therapy? So as you know, BAL is really the poster child of pediatric oncology success. It approaches about 85 to 90% cure rate with contemporary regimens. Similarly, in KK, we see the same across the years, and we have up to about 90% in taking all the BAL cases together. But as you know, the 10 to 15% are relapsed and refractory, and 2% actually have induction failures. And these are generally the high-risk group of patients, and these have not really changed over the years. So this does not reflect the increments up to 90%. These children have actually had unmet needs through the decades from the early 1990s, and something really needed to be done. So with the landmark success of the anti-CD19 CAR T, everyone is very, very excited. It still is a very promising therapy. But you can see that the early preliminary results of about 80% remission at about 3 to 6 months was not actually seen or maintained when the data was more mature, about 12 months. And there's about 40 to 50% that relapse. And, and this tells us that really this may not be the magic bullet for all, and there needs to be more things, more ways to help these children. This is not just particular to the Novartis, the Kymriah CAR that this result was eventually marketed as. This was actually something that was seen in all the other CAR-19, CD19 therapies, where the majority of relapses were CD19 negative relapses. So this brings us to the first limitation of single targeting CAR T, which is the target negative relapse. And the relapses generally, there are 3 main ways that a single targeting CD19 CAR T would relapse. The first is by receptor genetic mutations. And by this, it's quite interesting because the CD19 is actually a very important protein for B-cell survival. And therefore, you can't actually lose the receptor completely by mutations. What happens is that the binding site where the antibody binds to becomes truncated into all sorts of different forms where it's basically lost, although the CD19 is still present. And therefore, the CAR T can no longer recognize this particular binding site. The other target negative relapses happen in certain more stem cell-like B-cell leukemias, such as mixed phenotypic acute leukemias or the MLL rearranged ones, where the B-cell basically can acquire a more myeloid phenotype and therefore lineage change. And then there is a very rare phenomenon called epitope masking, where the B-cell leukemia actually gets a CAR T on it, and it actually basically covers over the antigen for which these CAR T is supposed to target. So what about other B-cell targets? So the other very promising B-cell target was CD22. CD22 is being used very successfully in the form of inotuzumab, which is a drug antibody conjugate that we use in refractory leukemias as well. And in the CAR T setting, CD22 was also very effective as a target. But then within 3 to 6 months, the early trials found that this very quickly led to a CD22 negative relapse when given as a single targeting CAR. And in fact, this made it, this was actually even faster and more frequent than the CD19 CAR T. And when they looked closely at the mechanisms of relapse, they found that there was really no change in the genomic and transcriptomic profiles of the relapse and pre-relapse samples. And therefore, it brings us to another mechanism, which is epigenetic silencing of the antigen expression. And therefore, a single targeting CD22 is not another CAR that would replace the very successful CD19 CAR. But moving forward, the concept is to do a dual targeting CAR T, because it's really immunologically really rare to be able to lose 2 antigens at the same time. This is it's a biologically very, very statistically difficult state to achieve. And therefore, dual targeting, where you target one or the other, allows the CAR T to overcome the antigen escape phenomenon of the leukemia cells. There are many ways to dual target the leukemia cells. One is using one single vector with 2 CAR molecules, and this single vector then sticks in 2 different CARs on a single T cell in a very consistent way and targets both epitopes. Then you have the bispecific tandem CAR T, which uses one single vector, but on that vector, there's just one co-stim domain and one signaling stem, but then there are two receptors that targets the two epitopes on the leukemia. You can also make two different CAR T products, but this is actually quite expensive and laborious, and then co-administrate them. Or you can actually co-transfuse the T cells with two different vectors. And basically what you get is a mixed pool. And sometimes you may get some differential transduction where not all the CAR Ts actually have dual targeting. Each of them have their pros and cons, which I will not elaborate given the interest of time. The second limitation of CAR T cells is the lack of persistence of CAR T cells. And really nobody knows, and I suspect this will be different for every disease, how long do you need the CAR T cells to persist to say that you have effectively treated and cured the patient? I mean, we don't want a CAR T to last forever because there's always an off-target effect, but you also want it to last long enough to actually eradicate and get rid of disease. So we need to really optimize how long we need these CAR T cells to persist. And the multifactorial there's multifactorial implications into how the persistence can be affected. It starts with the T cell collection, with the quantity, the quality, and even the subsets of T cells that you collect to make the effector CAR Ts. Then the manufacturing process has many variables in which the CAR T persistence can be affected. Primarily, one of them is the co-stimulatory domain, which is, the commonest ones would be the 4-1BB and the CD28, and the 4-1BB has been shown in many studies to be the more persistent CAR T, whereas the CD28 has a more rapid expansion and it's probably more cytolytic in the initial phases. So you've got a sprinter and a marathoner, and you can use them to treat the diseases that would require the different kinetics of the CAR T exploited. And the SCFV, so a lot of the CAR T designs use murine designs, and because the body tries to get rid of anything that's foreign, so a humanized design is always more persistent than a murine design. So that's one factor. And then, of course, the reagents, the cytokines that you use to transduce and expand the CAR Ts make a difference to expansion and the persistence in vivo. The conditioning regimen is also very important, as is the tumor burden prior to CAR T. We always like to keep a little bit of tumor burden to allow an expansion of the CAR T upon infusion. And then post-infusion, there are many other unknowns, such as the microenvironment, signaling pathways that can affect the CAR T persistence. So this brings us to other blood cancers. We actually, CAR T for B cells is effectively, something that's already commercialized, and we know there are limitations, but we can overcome these. How about other blood cancers? So for non-B cell malignancies, really one of the key limitations is finding the right tumor-associated antigen where you have nearly 100% killing of the tumor cells, but then have acceptable or no on-target off-tumor toxicity. In B-cell leukemias, the B-cell aplasia is very acceptable because all this requires is replacement IVIG, which the patient gets every 4 to 6 weeks. This is not the case in T cell targeting or myeloid cell targeting, because as you know, T cells are essential as neutrophils and the myeloid cells for protection against many life-threatening infections. So basically the ideal target is one that is necessary for the survival of a tumor cell, and therefore is expressed with high tumor density. You don't want to have these very highly expressed on healthy tissues. And then these have to be stably expressed on the surface as well. So these 3 criteria, and it's really not that easy to find. So some of the promising targets in TAL is the CD7, CD5. Basically, these 2 antigens are found on more than 95% of the malignant T cell blasts, and on the majority of the normal T cells. Some of the properties are exploited in different ways by different groups. The CD7 targeting CAR, one of the limitations of this particular antigen is that there is fratricide during the expansion phase of the CAR T manufacturing. And this is because the CAR T that targets CD7 also kills the CD7 that's expressed on its own effector T cell. However, CD7 is not pivotal to T cell function, and it was found that if you edit this out of the T cells and then you transduce these CD7 edited T cells, these CAR T expands, and what's even better is that it expands and it continues to be very cytotoxic without affecting its function. So there are many ways to edit out the CD7. You can do it by genomic editing as well as non-genomic ways. The non-genomic ways is really using a protein expression blocker to retain the CD7 within the endoplasmic reticulum or the Golgi body so that it doesn't come onto the surface. The next antigen, CD5, is also a good one. CD5 has a very interesting property that makes it quite ideal as a target. So CD5 CAR T cells, or in fact any activated T cells, actually downregulate the CD5, and therefore these CAR T cells are actually fratricide resistant, and they escape the fratricide, and they are very potently lytic. So we talked about two of the limitations of CAR T therapy for T cell ALL. The other limitation that we spoke about was the T cell aplasia, which requires a transplant to follow very quickly after induction of remission. The other ways of maybe addressing T cell aplasia is to use a less permanent expression of CAR T, using, instead of lentiviral, use the mRNA electroporation or the AAV vector delivery systems, where the CAR isn't as persistent, and it's a deliberate intervention for that. You can also use other types of T cells, like gamma delta T cells, that are not so related to T cell aplasia. Product contamination is rare, but this can happen, and therefore there are many ways to overcome challenges, and the CAR T for T cell ALL is coming along, but there are things that need to be overcome. So we can see that there are many trials going on. This is just a snapshot. It's probably not updated, but most of the trials are in CD5 and 7, and the rest of the CD30 trials are really for the adult T cell lymphomas. In AML, the CAR T is also a potentially very important tool in the box for very highly refractory AMLs. Of course, the limitation is stem cell aplasia, and this needs to be followed by transplant. So the first AML CAR T was actually against a target called Lewis Y by the group Ritchie et al. And this antigen was actually quite specific to the AML blast, and not found on the stem cells. But for some reason, there was quite limited efficacy of this CAR T. Since then, more promising targets have been found. So CD1, 2, 3, and 33 are the very highly researched ones. They're both expressed on AML and healthy progenitor cells. And CLL1 is a more recent target for AML. And what's nice about this is that they're not expressed on most of the progenitor cells and maybe sparing the stem cells. And also they are co-expressed with the CD33, and therefore can be a very useful dual targeting type of CAR in future for AML. So what are the solutions, right? So we may actually want to deliberately limit long CAR T persistence, because AML, when they relapse very aggressively. So they're not like BALs that relapse further down the road. So we may not need such a long-acting CAR T, and therefore to limit the CAR T persistence, things like suicide switches, using a CD28 construct, or using another mRNA electroporation instead of lentiviral may be some options. But really, the big question, the million-dollar question is, what is the optimal persistence to prevent relapse? And nobody knows this. Some of the creative other ways that are in the literature is basically using gene-edited stem cells from the same donor as a CAR to perform an allo transplant first and have CD33 negative stem cells in the recipient, followed by infusion of CD33 CAR T. So that's been done to some early success. And then what I think it would be probably one of the most important areas of research is to find new antigens that may be potentially better targets than 33 and 123. Some low mutation, AMLs are generally have a low mutational burden, but some other targets may be found, such as IDH1, IDH2, and the NPM. Differential RNA splice variants may be used. And there's a very interesting concept of a TCR mimic CAR T, where WT1, which is a very common antigen associated with AML, but intracellular. So what this CAR T does is that it actually targets the entire WT1 and the HLA-A complex, making it very much like a TCR CAR T, but it really uses the scFv fragment of the CAR to target this complex. So just to show you pictorially what it looks like. So using the scFv to target the entire peptide MHC complex. So I'll move on to CAR T in solid tumors, where this is definitely a more difficult terrain to drive the CAR through, if you like, and there are definitely more challenges than successes. And if you recall the introductory slides on the childhood cancers, which are incurable or very hard to cure, these are driving the field of the solid tumor CAR Ts in terms of what should be prioritized. So the three major roadblocks for CAR T cells for solid tumors that are basically still very much causing CAR Ts for solid tumors to remain in the preclinical or very early phase trial stage. One is that there is a lot of antigen heterogeneity in the solid tumors, unlike hematological cancers, where basically you have very well immunophenotyped and consistent expression of an antigen. In solid tumors, the target protein actually may not be present on all the tumor cells. And when they are present, they may be present in a very low expression profile. And again, because solid tumors arise from developing normal tissues, they actually have a lot of shared proteins with the healthy tissues, making the off-target toxicity a big problem. So homing is also one problem seen in solid tumors. T cells are not endogenously primed to go to non-hematopoietic tissues outside of the spleen, liver, lymph nodes, and the bone marrow. And so homing to a tumor site is sometimes what prevents a very good CAR T from actually reaching clinical efficacy. The tumor environment of a solid tumor is also extremely inhibitory to the CAR T. It is quite a hypoxic environment, and there are many checkpoint inhibitions and regulatory cells in that environment that impede the effectiveness of the CAR T when it actually is used clinically, as opposed to what is in the Petri dish in the lab. So there are, this is as of February 2021, so it's pretty updated, but there are, reasonable number of pediatric studies going on for solid tumor CAR Ts, and these are focused on CNS tumors. These are the main receptors being researched: the EGFR for GBMs, high-grade gliomas, HER2 for a wide array of CNS tumors, GD2 positive tumors, which are in the CNS arena would be the DRPGs, and B7H3, which is a checkpoint molecule, and actually a very promising one. It's present in many cancers and is touted as perhaps a pan-cancer antigen. And these are for the medulloblastomas and high-grade pontine gliomas. Similarly, there are about 12 trials in progress for sarcomas, again targeting GD2 and HER2. And in neuroblastomas, there are about 13 trials. Nearly all of them have anti-GD2 as the target for the CAR T. There are some novel trials out there, and some of them combine it with checkpoint blockade or with cytokine drivers. So one of the ways for CAR T in solid tumor is to really develop a multi-targeting solid tumor CAR T, just because of the heterogeneity seen in the solid tumors. It's probably something that would be needs to be further developed in order to make a very effective solid tumor CAR T. So there are many types of CARs where you could either have a OR gate where you recognize one or the other antigen in order to activate the CAR. You have dual targeting and tandem targeting. With the AND gate where you have to recognize both targets in order to activate the CAR T cells. And you have the NOT gate where a dual CAR T cell basically recognizes one tumor-associated antigen, which may be expressed on another normal healthy tissue, and the presence of that normal healthy tissue other antigen prevents the CAR T from being activated. So I think this brings me to the last section of the talk. So, CAR T hacking, which I like to see it as, is basically gene editing the CAR T to overcome some of the challenges that are already being seen in early phase clinical trials. And therefore, the back translation is always very important. It targets the right antigen, and you can design it such that the murine SCFVs are replaced by humanized versions, so that you don't generate such a big anti-CAR immune response. The spacer is what gives the flexibility of the head, which is the SCFV, in maneuvering so that it can find the antigen on a tumor cell. And the spacer length is also important to make sure that immunological synapses is not too big. And you have other spacers that may trigger tonic CAR signaling, which is no good. And these are things that should be modified. You have the transmembrane domain, which are made of commonly the CD8 alpha hinge or the CD28. And then you have the intracellular domain, which is the co-stimulatory domains, as well as the CD3 zeta signaling. So all of these things can be tweaked to make your CAR T better, faster, stronger, and many people are working on each individual segments of it. The CAR extrinsic factors would be the transgene delivery system. So we know there's the lentiviral system that causes quite permanent integration to the genome, but bears the risk of insertional mutagenesis. And there are different gene editing approaches. Some of them are genomically safer than others, and less disruptive than others. So as we as presented in the earlier slide, basically I just wanted to show that under each modular modular compartment of the CAR T, there are all the different ways that have been researched on, and as we conduct our research, we add on to the bullet points of how we can modify our CAR T. So there are many obstacles, but there are also many engineering solutions, which is nice. And for each obstacle, there are work really needs to be done and shared generously between groups. So for T cell fitness, the promise of allogeneic off-the-shelf CAR Ts are probably the holy grail for CAR T in my view. That to overcome the need for autologous CAR Ts from patients that's already intensively treated with a very little therapeutic window, off-the-shelf CAR Ts really hold the promise for something that can be used in a very less individualized approach. Tumor trafficking can be improved using multi-specific CARs, having CARs that also secrete BiTEs, having CARs that secrete some chemokines. To overcome the tumor microenvironment. You have CARs that may have alternative CAR structures, CARs that secrete cytokines such as armored CARs, and all the different types of ligands that might allow the CAR to penetrate the tumor better. And to maintain a acceptable toxicity profile, some of the safety switches, logic gatings, or using small molecule adapters to make the CAR safer. These are some of the engineering solutions that we have that are being investigated on by our group and many other groups. So the next few slides actually have more ideas on more pictorial forms of how all these engineering techniques have overcome the main challenges. And I'll just highlight a few. So toxicities. So there are some adapter molecules that basically allow you to control when the CAR T is activated against a tumor cell, such as the folic acid fluorescein adapter molecule. And then using other types of inhibitory agents like bizatinib to basically stop the CAR T. So these small molecules are something like a drug that you take to either activate or stop the CAR T. Suicide gene basically has the same concept, but instead of small molecules, you introduce an antibody that targets a suicide receptor that could either be a CD20 or an EGFR, and the corresponding antibodies would be rituximab and cetuximab. And I think the rest are there. So to improve the CAR specificity, there are also many other ways. We talked about some of the multi-targeting gating approaches. So you have the split CARs where a CAR alone in contact with the antigen does nothing, but a CAR in contact with one antigen, but also a second antigen that makes, to kind of let the CAR know that this is definitely tumor and not some healthy tissue. This second signal combines with the first signal to generate T cell activation. So this is an example of an AND gating or a split CAR. You also have inhibitory CARs where you have one antigen that basically is able to be activated, and basically another CAR is engineered to kind of have the function of a checkpoint blocker, but the checkpoint blocker is basically triggered by the antigen B, which is expressed on healthy tissues, and in contact, there's checkpoint blockade and the CAR is not activated. And there are many, many other ways in which these clever engineering solutions can improve our toxicity profile. We talked about, again, multi-targeting to help with antigen escape. And exhaustion persistence is probably an interest of mine, really, to how to get CARs to persist better and use this in tumors that actually require better CAR persistence. So armored CARs are the CARs that really may have maybe secreting cytokines, have extra cytokine receptors, other ways of activating the CARs, and also they may be secreting BiTEs. So these are CARs that actually overcome exhaustion and persistence. And finally, of course, to really overcome it, allogeneic CARs would probably give you the best T cell effectors. There are also combinatorial treatments with checkpoint blockades and some other gene editing strategies to alter T cell pathways to overcome the energy. We talked about AlloCARs. For AlloCARs, the main two limitations are, firstly, the allogeneic CARs can cause GVHD introduced. And so therefore, in order to reduce GVHD, many of us are investigating non-alloreactive T cell subsets, including viral specific T cells, T gamma delta cells, genome editing to disrupt TCR alpha beta TCR alpha beta on the CAR itself, so that it does not recognize the HLA molecule that triggers GVHD. And then, of course, TCR expression is also something that can be worked on. So if you do an expression blocker, the TCR doesn't express, and therefore the CAR does not have a TCR, as TCR-less. To prevent rejection is also important for AlloCAR Ts because that limits the persistence. And of course, to do this, we basically get rid of what promotes a rejection, which is typically the MHC1 molecule. And to do all these genome editing, many approaches have been applied, some with better outcomes. So there are many AlloCARs trials. Most of them are actually probably from China, and most of them are still working against the B-cell malignancies. So just a summary slide, because there's been, it's quite a broad sweep of many concepts. So just the take-home messages are that CAR-T really has changed the prognosis of the largest group of difficult to cure pediatric cancers. Primarily, the key success is in relapsed refractory B-lineage leukemias, and now we're looking to apply this to the other unmet needs that we have. Some of the promising CAR-T applications that have come about in the last couple of years would be CAR-Ts to T cell ALL, AMLs, and GD2 positive tumors. And then B7H3, HER2, and EGFR are promising antigen targets as well, even in the pediatric solid tumor sphere. Many of these new CAR-Ts, however, are conceptually really exciting preclinically, but meaningful clinical efficacy actually still remains very much to be proven, but never give up. So gaps still do exist, and we talked about all of them. But then with every gap, there are engineering solutions, so we have to keep working on them. These include genomic and non-genomic hacking of the T cells. And also remember, other immune effector cells may be the key, and these can also be directed by CAR as well. The main thing is that clinical trials for CAR T cells are very expensive to start, and there's a significant regulatory burden as well to get CAR Ts translated into clinical practice. But within the passionate few of us, well, we see that there is a point to doing all of this. So just to introduce the group, so we have a small but growing clinical and translational team led by Prof. Wing Leong, and some of us, as well as a group in the lab. And we work very closely with the cell therapy facility in HSA, who are really excellent, and we are very grateful for their very close collaboration in manufacturing our CAR-Ts. And so with that, I thank you. Invite any questions, leaving you with my pet mantra. If you want to go fast, go alone. If you want to go far, go together.
Okay, thank you. Thank you so much, Dr. Seng, for the wonderful presentation. And now is the Q&A session, and I invite Dr. Ng to join Dr. Seng for this Q&A session. And I can see that there are already 3 questions presented at the Q&A box. Maybe Dr. Seng and Dr. Ng can address these questions, please. Thank you.
Okay, I'll just go down. So recently, CD19, 20, and 22 triple CAR was published. Does this have significant advantages over the dual CAR? So I think the results are really too early. I don't think there is this, for me, I don't think B-cell, in the B-cell ALL, there's a significant advantage of triple targeting over dual targeting, because the antigen escape, as it's been shown in dual targeting, is really not a mechanism of relapse, even with early experience of dual targeting. I think the main problem is the persistence of dual targeting. I'm not sure what the persistence of a triple CAR is compared to the dual CAR. The next question is.
So the next question is, let me speak now for you. Okay. So so it's probably one of the clinicals. groups. So on the slides on the high risk group, age group for childhood cancer. So I appreciate if you could share more on the reasons for those being high risk group age groups, and if any of the new CAR T therapies are targeting on those high risk age group. Okay, so probably need to refresh like what are those like high risk age group and so on. Please.
So yeah, so the high risk age groups. So we think about them more as high risk disease groups. So the high risk disease groups are really probably to us the commonest would be the neuroblastomas, as well as the high risk sarcomas, as well as the brain tumors. Those are the three high risk disease groups. And I share more on the reasons. The reasons for these, why they're high risk. Okay, that's a good question. So the reasons why they're high risk is because these are tumors that have proven to be rather chemo resistant, and we feel that we have actually maximized the efficacy of chemotherapy and radiotherapy for these tumors, and therefore they basically need something with a different mechanism of killing. As you know, there are 5 pillars of killing a tumor. So the first is chemotherapy, the second is radiotherapy, the third is surgery, the fourth is small molecules, and the fifth is immunotherapy, which includes CAR T. So basically, very traditionally, if chemotherapy, surgery, and radiotherapy cannot deal with these cancers, they generally become very high risk because they actually need something else, and they high risk because they relapse very quickly and we cannot cure them. So the new CAR T therapies are targeted. So as mentioned, a lot of the high risk disease groups for childhood cancers are driving the priorities for CAR T translation in the solid tumor field. So many of these are actually targeting the anti-GD2, which is expressed on not just neuroblastoma, but also on osteosarcomas and some brain tumors as well. So basically, translation should always be with a goal, and therefore the goal is for treatment of cancers that already maximize the treatment effect with chemo and radiotherapy.
Thank you, Dr. Seng. So next questions will be one of the examples you cited in your slide. So it's about the CD34 operations and before transplantations together with the CD33 patients with CD33 targeting CAR. So the question is like, does it actually fine to do that? So what's your view on it?
So it's quite interesting. So when I read this paper, I also had the same question, but this paper showed that CD33 deleted stem cells could actually repopulate and regenerate and form the normal repertoire of hematopoietic cells. So yeah, so I'm not sure what the essential function, but basically they have in the paper they have alluded to the fact that it has not affected the ability of the CD33 negative stem cells to regenerate a whole repertoire of hematopoietic functioning cells.
Sure, I guess you're talking about the paper from UPenn.
Yeah.
In fact, on top of that, I think there's another group in University of Columbia doing the same thing, and then also find that the CD33 abrasions is fine, at least for the experiment. Long term, we don't know.
Yeah, long term, we don't know.
Okay.
Correct. Yeah.
Okay, so the next question is like, do you think that time of treatments for cell therapies make a difference to the clinical outcome? So is there a need to push cell therapy forward to an earlier line of treatment? And if so, what can doctor do better to push it forward? So I think you are in a real position to answer this.
Yeah. So I think this is the wish. We believe that there is obviously an optimum time to provide cell therapy, but the more upfront you provide it, basically the two main advantages. One is that in the autologous setting, you actually get better T cells. You don't have someone who's been battered and bruised by a lot of chemotherapy. And that's the first, so, you know, that your CAR T product. The second big advantage of pushing it forward earlier is that if this is a definitive living drug, and living drug means that it persists long enough to eradicate and cure you, and you actually don't need anything else after that, then why not? I mean, why not do it at a time where you have just enough disease that can be removed by CAR T and not have to undergo any more of the intensive treatments like transplant, radiation, and all of that. So I think many of us actually trying to answer this by rational clinical trial designs. In BAL, we are trying to stratify high-risk MRD patients who are basically at very high risk of relapse to get the CAR T earlier, and try to use this in a more upfront setting.
So I hope you answer well. And then the next question is so would like to have your email so that always ask for collaborations. So this is like to discuss our NKG2DL CAR. So it's like something on the gamma delta T cells. So
of course, we can we can have a offline correspondence. We're very open to collaborations.
Good. And the following questions again also is on gamma delta T cells. So audience would like to know, like, what's your thought on the use of developments or the developments of this allogeneic gamma delta T with a CAR that could recognize multiple antigens?
I don't know much about allo gamma delta T cells. Although, you know, my thoughts it'll be a good effector cell. You know, very little GVHD risk. I'm not sure about the persistence, because in the unedited version that we are familiar with as a transplanter, these T gamma delta cells don't persist for very long. But you know, if there's a non-alloreactive gamma delta T cell with a CAR that can target multiple antigens, I think that would definitely be something of great potential. For AlloCAR model.
So it seems like there's with a lot of potentials cooperations. At least then some of the local products will be able to drive in the clinics. So and then allow them to hopefully to work with you. So before going to it further, so let us answer the next question. So this is more to the diagnostic, and the question is like, can NGS, whole genome sequencing, help in the discovery of childhood cancer? So, Dr. Seng.
So I mean, I think. Any kind of high throughput sequencing, and either proteomic or RNA, these, as long as I think a combination of all these technologies will help us find out the profile of the tumor, and then hopefully through that we find the best tumor associated antigen. I mean, that's my take on how these NGS type of technologies may be able to help the field of not just CAR T, but basically any kind of immunotherapy approach to childhood cancers, to finding the right targets for us. Picking Pen, any inputs? You may be more familiar with the available technologies.
Yeah, so I kind of know it, but for the clinical side, especially for most of our audience, or which is not like have a medical background. So what actually would like to know is, like, does the NGS sequencing or other sequencing is actually part of the standard tools for examinations in the clinic, at least say for the childhood cancer? Is it now in use?
So NGS, It depends what, I mean, there are very many ways we sequence. One of the applications for NGS for us is in disease monitoring. It's not something that's been validated or optimized, but we use it to basically characterize very, very completely the profile of a leukemic blast, and we can follow the very, it's almost like a fingerprint for this leukemic blast through treatment. So that's what I think the most kind of immediate application that jumps to my mind. But I think a lot of the other, besides, you know, response to treatment, the NGS has helped us very, very much with tumor profiling. So like my pathology colleagues will actually use a lot of these sequencing, not necessarily NGS, but a lot of these sequencing technologies to give a molecular diagnosis of the tumor. Sometimes we have, you know, histopathologically, it's very hard to classify a tumor, but we have a molecular profile that tells us how the tumor behaves. Very often this is something that we see in some rare sarcomas or some rare brain tumors. And we've definitely had some of these profiling diagnostics help us define the tumor better and its behavior.
Wow.
But yeah, I
Thank
hope that
you.
answers the question.
Definitely. Okay, so
Yeah, I think that's all for the questions. I think they've been answered. Well, thank you everyone for your participation. I think it has been a great session. I think you have learned a lot from today's presentation, and thank you so much for Dr. Seng and Dr. Ng for your presentation and your answering our questions. Okay, that's the end of the lecture, and we will be seeing you next month. Hopefully we will have another round of learning from the experts. So now it's about 1:02. I think that's the end of the session, and hope to see you guys again next month. Thank you. Thank you.
Thank you.
Yeah.
thank you.
Can Dr. Seng
Bye.
and Dr. Ng, can you look at the chat box? Okay.